Hello, I'm Dr. Ken Landa. Thanks for watching. Let's talk about Effexor or Venlafaxine. It's a structurally novel antidepressant. The immediate release form was approved by the Food and Drug Administration in 1993 and went off patent 2008. The extended release form came on the market 1997, went generic in 2010. The importance of going generic means that it became reasonably priced. Structurally and pharmacologically, Effexor is related to Tramadol. Tramadol, the painkiller. It's not related to the traditional antidepressants like the selective serotonin reuptake inhibitors, Prozac, Celexa, Zoloft, or the tricyclic antidepressants, or even the MAO inhibitors. It is a serotonin norepinephrine receptor inhibitor, and it's approved for use in major depressive disorder, depression, generalized anxiety disorder, anxiety, social anxiety disorder, and panic. It's used very frequently, but off-label, without FDA approval, for treatment of diabetic neuropathy or for prevention of migraine headaches, although in some people it can cause flares of migraine headaches. It's used for treatment of menopausal hot flashes and attention deficit hyperactivity disorder, ADHD, or sometimes ADD, used for treatment of obsessive compulsive disorder and chronic pain syndromes, but again, without appropriate studies and without FDA authorization. Well, it was originally considered a second-line antidepressant because of all of the side effects associated with the drug, but now because of all the direct-to-consumer marketing, most people would consider it a first-line drug. But if we look at the tolerability, we find that this drug is not ranked near the top of the drugs that are well tolerated. And as a matter of fact, if we look at all the antidepressants, Effexor ranks near the top of the list of drugs that people discontinue because of the side effects. As far as being effective for an antidepressant, well, all of the drugs seem to work about the same. They have different side effect profiles. Some people seem to respond better to one versus the other. Some people like Coke, some people like Pepsi. Well, we can't tell beforehand which one is going to click with an individual patient. Typically, the drug is started at a relatively low dose, 75 milligrams per day, gradually increased up to maybe about 225 milligrams. On most of the scales of depression, the drug seems to work. It seems to work better, at least, than placebo. But it could take up to about 12 weeks to work. And then when it works, it's reduced the symptoms. It hasn't necessarily eliminated the depression. Fortunately, we can individualize the therapy. When we talk about the immediate release form, it comes as a 25 milligram, 37.5, 50, 75, and 100 milligram capsule. If we look at the extended release form, it comes in 37.5, 75, and 150 milligrams. Well, if we start with the drug, let's say the immediate release form, the total daily dose is 75 milligrams, but it has to be divided into 2 or 3 different dosages. So you take one morning, midday, night, one morning, nighttime. Take it with food, that's fine. And you can increase the dose, or it can be increased, every week or so as necessary until you get a benefit, a significant benefit, increase from 75, go up to 150 milligrams. Sometimes people have to go to 225 milligrams, but that's about the top of the amount, except in extraordinarily severely depressed people. Then a dose of up to 350 milligrams might be necessary under very careful observation. If a person is going to take the extended release form that's much more convenient, a person would start that at 75 milligrams, typically just one dose, one time per day. Some people, because they're elderly, might start at a lower dose, 37.5 milligrams, and that can be increased again up to 225 milligrams. Single dose, you take it with food, could be taken in the morning, could be taken in the evening, but the same time each day. And with all of the pills, you don't chew them and you don't crush them, you swallow them whole. Now, if you're changing from the immediate release to the extended release form, just add up the total dose and take it as one pill of the extended release. If you happen to suffer from either mild to moderate liver or kidney disease, then the dose might have to be reduced by about 50%. If you have severe liver or kidney disease, this probably isn't the correct drug for you. Now, when people first see their physicians because of depression, it's important to differentiate major depressive disorder as a disease versus depression as the initial symptom of bipolar disorder. We used to call it manic depressive disorder. If a person has manic depressive disorder, then Effexor probably isn't a good drug to take. And somewhere around 6 million people suffer from manic depressive disorder. So it's important to make the distinction. If a person has a family history of bipolar disorder, or there's a family history of suicide, then you have to be extraordinarily careful. It seems that when we compare Effexor to the SSRIs, this drug, the Effexor, might be more likely to precipitate or lead to a manic attack, and there's some question whether it's associated with an increased risk of suicide. And talk about suicide, as with all of the antidepressants, they all carry a black box warning, and that black box warning by the Food and Drug Administration says, hey, if you're taking the drug, especially if you're less than age 24, you have an increased risk of suicide. So you need careful monitoring, especially when you start taking the drug, or if the dose is going to be changed, and especially people who are taking the drug who develop some kind of peculiar symptoms. So people who all of a sudden become anxious or agitated or seem to complain of panic attacks or have insomnia or hostility or aggressiveness or impulsivity. Well, those people need to be considered for other kinds of therapy. Now, once you take the drug, the Effexor, it's going to be metabolized in the system to its major metabolic byproduct that's called O-desmethylvenlafaxine. We call it ODV. It has the same effect. It's exactly the same effect inside the body as the major product called the Effexor. It doesn't have any affinity for the muscarinic sites or the histaminic sites, so that's good. So that potentially reduces some of the side effects. If you take a dose of less than 150 milligrams a day, seems to work mostly on serotonin. If you take it between 150 and 300 milligrams, then it's going to work on both the serotonin and the norepinephrine receptors. If you take even a higher dose, it might actually involve the dopamine transport. Now, most of the drug that you take by mouth is going to be absorbed by the intestine, the gastrointestinal tract. It's going to be metabolized in the liver to that O-desmethylvenlafaxine. And the importance of O-desmethylvenlafaxine is that drug is marketed, that chemical is marketed as Prestique. Seems to be another antidepressant drug. It's going to be metabolized, as I say, in the liver, and then it's going to be excreted in the urine. The half-life is going to be about 5 hours for the Effexor, and for the ODV is going to be about 11 hours. And since that's relatively short, that means that if you forget even one dose, you might have some withdrawal symptoms. As far as pregnancy is concerned, it's not well studied, but it's clear that you should take it only if it's needed. If you take it in the first trimester, it's been associated with the potential for miscarriages and brain abnormalities and cleft palate and certain heart defects. And if it's taken late in the third trimester, then the newborn might have significant potential for side effects that cause respiratory distress and cyanosis and apnea, and seizures and temperature instability and difficulty feeding and constant crying and irritability and jitteriness. We don't know whether it's a toxic reaction or a discontinuation reaction, actually. Lactation, breastfeeding, again, not appropriate. Pediatric dose, well, it's sort of iffy. Common side effects of the medicine include loss of appetite and vomiting, constipation, dry mouth and dizziness and sweating, and certain sexual problems like abnormal ejaculation or impotence can cause tiredness and insomnia and tremor or shaking and yawning. And interestingly, can cause an interstitial lung disease. So if you're taking the drug and you develop a cough or chest discomfort or shortness of breath, immediately to the doctor. And it can cause a slight increase in the heart rate. So it probably is not appropriate for people who've had a recent heart attack or people who are suffering from unstable angina. And it may increase the blood pressure. In some people, it increases the blood pressure by 10 or 15 points. That's a relatively small number. However, enough so that when you start the drug, you should have your blood pressure monitored, and then periodically thereafter, and it can cause a dilated pupil, and that means that if you have an increased intraocular pressure and you're at risk for narrow angle glaucoma, you might have a potential problem. It also can be associated with weight loss. It can make you lose more than 5% of your body weight. Now that's in about 1 in 16 people. It's more than with other antidepressants, and it's certainly not to be taken as a weight loss drug. We don't even know how it interacts with other weight loss drugs. The drug also, if it's given to juveniles, people under age 17, might decrease the linear growth. It can be associated with a reduced seizure threshold, so people who have epilepsy might be more likely to have epileptic seizures. It can cause abnormal bleeding, so especially if you're taking it with aspirin or nonsteroidal anti-inflammatory drugs, or you're taking it with a blood thinner. Have to be careful because you could develop nosebleeds or bleeding into the skin or bleeding in the intestine that could be fatal. Effexor and Effexor extended release have been associated with a significant number of side effects according to the Food and Drug Administration, their adverse event reporting system. By the end of 2018, serious cases and or death, about 13,000 cases, death, just a little shy of 800 cases. Now, whether that's cause and effect can't be determined. We just know there is that association. If you stop taking the drug, you're likely to have a moderate to severe recurrence of symptoms, more so than with the other antidepressants. Possibly that's due to the short half-life. If you abruptly discontinue the drug, you could suffer from agitation and confusion and difficulty concentrating. You could have impaired balance. Some people develop diarrhea or dry mouth or dysphoric mood. Sometimes symptoms can be mistaken for recurrence of depression. A person suffers from fatigue and headache and vomiting, nausea, nightmares. You can have what we call brain zaps, where you have peculiar sensory symptoms. This can occur even if you are late in taking your next dose by 8 to 12 hours. So if you normally take the medicine in the morning, you better continue taking the drug in the morning. Set your clock so that you remember to take it. Or in the evening, again, the same sort of thing. Don't neglect taking the pill. And don't take it within 2 weeks of taking an MAO inhibitor. The two drugs don't like each other. If you take the two too close together, you may well suffer from muscle problems, sweating, headache, nausea, dizziness. The body temperature can go up. Some people have had seizures or even died. And there's another kind of a syndrome that we see with these kind of drugs, and it's called the serotonin syndrome. The serotonin syndrome, potentially life-threatening, especially if it's used, if the Effexor is used with other kind of drugs that interact with serotonin metabolism. But the drug can cause the serotonin syndrome all by itself, but especially if you take it with another antidepressant or a triptan that would be used for treatment of migraine headaches, or St. John's wort, or amphetamines, or even the Tramadol or fentanyl. The symptoms of the serotonin syndrome can come on very quickly: agitation, hallucinations, and coma, irregularity of the heartbeat, fast heartbeat, labile blood pressure goes up and down, body becomes excessively warm, reflexes are increased, person becomes incoordinated, has nausea and vomiting and diarrhea. Also, you have to be careful taking this drug with alcohol, and rarely it can cause a false positive test for either PCP or cocaine or amphetamine, since the drug seems to work fair on depression. People who are taking the drug need to be periodically reevaluated to determine if they should continue taking the drug. Now, as with all of the antidepressants, this one's been mired in a significant number of lawsuits that are ongoing at the present time, but the good news is that the price of the drug has come way down. So if you're taking generic Effexor, 75 milligrams, and you're going to take 2 a day, the cash price would be somewhere between $100 and $125, but if you get a coupon that you can get online for no cost, say at GoodRx, the price can be as low as $3 to as high as $48 at Walgreens. If you're taking the extended release form, well, if you're taking 150 milligrams and you're taking that 1 time a day, the cash price is between $60 and $126. Again, Walgreens is $126, Costco much cheaper. If you have a coupon, the cost would be anywhere between $6 and $35. Again, the $35 is at the Walgreens. But if you buy the brand name drug, if you want the Effexor extended release form rather than the generic Venlafaxine, then the cost will be about $500. So when it comes to antidepressants, this is just another one. There's nothing special about it. It doesn't have any good, unique features, but it does have some unfortunate negative features. And unfortunately, there are an awful lot of people who are being treated with antidepressants who probably shouldn't be. And the more we learn about the antidepressants, the more we know that most people have mild depression or mild to moderate depression, and the drugs might not work all that much better than placebo. So anyway, there's something for you to talk with your doctor about. Thanks for watching. I'm Dr. Ken Landau.